Today I want to share my story, and this will be a little bit an interactive talk. So maybe some of you may choose to a different path, maybe after residency. So I'll start with a couple disclosures. None of them are related to this talk. I have a couple objectives. One of them, we'll talk about the new field of endocrine hospitalist. We'll talk about some of the initiatives, and maybe we'll talk about some cost savings as well. I recently finished the MBA program at the Johns Hopkins Carey Business School, and my wife always like, well, I married the doctor, now all you talk about is the money. But guess what? Healthcare is just another business. So whatever we do, whatever the quality improvement work we do, we always have to mention about cost savings or some financial impact. So I'll start with a question, and this is a question for all of you. So how would you describe a hospital-based endocrinologist if you were a hospital administrator? Do we have administrators here? Anyone doing administrative work? Yes, you do. Chair of medicine is here, program residency program director. So do you think it's an expense or an asset? What do you think?
They view it as an expense.
So expense? A little bit of what? A little bit of expense?
No, more expense than asset.
More of an expense than an asset? Can you explain why, Joe?
Because we don't generate enough income to qualify as an asset.
Yeah, we don't generate enough income. If you look at the endocrinology practices of what we do, we can generate only so much income by seeing the patients and billing their insurances. And some patients could be uninsured, so they don't get paid much. So I actually agree with you that if you look at the ledger, if you look at the profit and loss statement, we endocrinologists are an expense. But let me see if I can convince you it's a little bit different in the next 40 minutes we have here together. So I'll start with my story. Right before residency, I spent a year falling in love with the field of endocrinology with my dearest mentor, Adrian Dobbs. We published some papers, we worked on testosterone, and truly Adrian convinced me that I should become an endocrinologist. Though she said, well, Misha, remember, endocrinologists don't get paid much. I was like, well, but I really like the field. Okay, go ahead. And after the residency, I spent the amazing 3 years at the NIH, and I have wonderful two pediatric endocrinologists who were my mentors, Konstantin and Maya Lorish. So this is the class of 2015. You may see some familiar faces. So when you were about to graduate, any fellows here? Do we have fellows here today? No? Any residents here today? Anyone is a third-year fellow, resident, second-year resident? So what's the question you usually get in the end of your last year? Exactly. What's next, right? So I was asking myself the same question. So how do you look for a job, by the way? How did you look? What's your name? Sorry.
I'm James.
Hi, James. So did you start looking for jobs?
I'm applying for fellowships.
Okay. Okay. You're applying for fellowship. But if you look for a job, I mean, what do? You start with Google, right? Or you start asking people around, like, oh, do you have a job? Or do you think I can get a fellowship spot? So I just Googled endocrinology jobs near DC. You can see there's a physician endocrinologist. So this is actually a part-time position in my team, on my team. There's a MedStar. MedStar is looking for an endocrinologist. Unity Healthcare. Yeah, I don't know. Are you looking for an endocrinologist? No? So what is that? Well, fake news, yeah. So what most of the jobs offer, you usually start with 7 or 10 half-day clinics, right? Depends where you start, but If you are lucky, or if you are can prove what you want to provide, do some clinical research, you may get 80-20 or more likely 90-10 clinical and do some research or have some pseudo protected time. In reality, you do 100% clinical, and on weekends you do your research. You can, one of my mentors, Gary Hammer, who is the endocrinologist in Michigan, told me, like, Misha, what you need to do is just get a grant and just buy yourself out. Just get those clinics out of your schedule and just do clinical research. If you're part of wonderful academic institutions such as Georgetown or Hopkins or some big academic centers, you'll get fellows, residents. Do you get nurse practitioner students here? No? Do you have PA students here? Yes, you have PA students come and rotate with you?
We have in the hospital.
Yeah?
Not rheumatology.
But you'll see that, yeah, you'll see more and more advanced practice providers coming doing their rotations. And you always get a call, right? 1 in 6, 1 in 4, 1 in 3, whatever you get. But frankly, none of those jobs were exciting. I did apply to a couple of jobs. I applied for a job at NIH to become a staff clinician. I didn't get it. Two of my close friends and other co-fellows got it, Andrew Demidovich and Jenny Blau. I applied for a job in New York, but really, for some reason, was just not there. My heart was not there. It's like, I need something different. So, what do you think is the fastest growing medical specialty in the US? Hospitalist? How do you know that? Do you know why? Do you know why hospitalist is the fastest growing medical specialty in the US?
Pays well,
Pay is better, okay.
hours are more defined.
So hours are more defined. So you do 10, 12-hour shift and you go home. Anyone else? Why do we need hospitalists? There's more demand. Why would there be demand for hospitalists?
The inpatient business is booming.
Inpatient business is booming. I mean, what, more patients are being hospitalized, I think?
Because there's not enough outpatient physicians doing a good enough job to keep patients from being inpatient.
Very good. There's almost impossible to find a primary care doctor in the community. So some people end up being in the hospital, going to the hospital to get their primary care. Anyone else? Lots of chronic diseases, right? So as population gets older and older in the United States and elsewhere, there are more and more hospitalists. Anyone else?
I think big reason is it used to be in the old days that your primary care doctor would come and see you in the hospital. Most primary care doctors don't do that.
So what Dr. Janczyk is saying is that in the past, maybe 20, 30 years ago, when we were not, well, I was not practicing medicine, your primary care doctor would come to the hospital, round on you in the evening or right before, during his lunch break, and then run back to his office. And then if you were on the lunch break, would come back again in the evening and help with discharges, sometimes not, and then the big call. So one of the main reason why hospitals decided to invest in building this field, the field of a hospital, is because they needed help from a more efficient way of managing people in a hospital. I mean, it was not unusual for people to stay 20 years ago, maybe 6, 7, 8, 9, 10 days in the hospital. Now, out, right? You admit a patient, you work him up very quickly, whatever needs to be done, out. Be discharging home, discharging to rehab. I mean, we have internal medicine residents here, right? So what do you do? What's the key? What do you do when you're floor rotations and medicine rotations?
From the time of admission, you think about dispo.
Exactly, exactly. So you admit the patient and right away you want to know, is this patient, where is this patient going to go? What's the family situation? So I actually truly consider it a hospitalist job. So this is NIH Clinical Center. This is in Bethesda. This is Suburban Hospital. So what I've done, as soon as I became a second-year fellow, I was allowed to moonlight. I was like, perfect. I'm going to become a hospitalist moonlighter. So on September 20th, I started doing my shifts. So every weekend or every other weekend, I was trying to make some extra money. So I hop on the bicycle on Friday afternoon after being done with my NIH responsibilities, bike to Suburban Hospital where I would admit patients in the emergency room as a hospitalist. And I loved it. Absolutely loved it. Suburban was a member of the Johns Hopkins Medicine, so it sounds cool. But what I noticed is that there are a lot of patients with diabetes. In fact, every fourth person who would walk for any reason, whether it's a heart attack or a stroke or belly pain, would have diabetes. And people at Suburban Hospital, even though it was considered a member of Johns Hopkins Medicine, they got not a very optimal diabetes care. I remember sitting in the ER at night and one of the hospital, hey, I heard you're endocrine fellow. I was like, yeah. It's like, do you know how to do those pumps? It's like, yeah, I got a chance to hold a few of them. It's like, this patient is on the pump and his sugar is 400. I really want to discharge him because I don't know what to do anyway. So can you help me to discharge him? Diabetes is a very expensive disease. And again, comes back to my wife who's always complaining that I started thinking about every disease as how much things cost. So we get a lot of chronic complications, heart disease, complicated pregnancies, more pain, getting more and more medications. And ultimately, it leads to increased length of stay and increased readmission. And if you're a practice administrator, or if you're a hospital administrator, they think about money. I mean, it costs money. So each patient stays in the hospital. Each hospital is a little bit different. Could be $3,000, $4,000, depends where they stay. Diabetes is also very expensive. We don't have the recent data, but we think that more than $300 billion spent per year on diabetes. But every $7 healthcare dollar being spent in the United States on diabetes. Can someone name me this country? Very good. Have you been there? Okay. Where did you go?
My parents were born.
Okay. So where do you usually go in Peru?
Lima.
Lima. Okay. What is this? This was a hint. Have you done this before? You should definitely go. It's amazing. In order for me to convince my wife to finish her PhD, finally finish her PhD program, I actually booked the flight on May 15 to Peru. And I said, you have to defend your PhD by May 15. And she actually did. So we went hiking. So Peru gross domestic product, which means total cost of all of the goods, all of the services. You fly to Peru, you check in the hotel, you spend some money, you buy some food in a local restaurant, all the tourism, everything the country creates, how much US spends per year on diabetes. So has anyone heard about the hospital readmission reduction program? Yeah, anyone heard about it?
Yeah, we all know about it, but not in detail.
Yeah, so what do you think it's about?
You get penalized if patient that's readmitted within a certain time.
Yeah, so hospitals, so CMS, the Center for Medicare, and is penalizing hospital if patients stay too long, and we are reducing their payments by this amount, and it's all in the public domain. You can look up any hospital. I just look up the Georgetown University Hospital. Usually there is a link you can click to see what's the actual value in dollars, but for some reason this website was down, so I couldn't bring the numbers. But we are talking about anywhere between like 50, 60, $100,000 to sometimes up to $1 million, depends what's the total number of payments. So being in blue means that every year MedStar Georgetown University Hospital, this hospital, was paying a little bit of money, thousands of dollars, for just in penalties. And you can look up also in the hospital acquired conditions. So I made a decision after I knew I did not get the staff clinician job at NIH. Like, I'm just gonna become a hospitalist. So I went to the Suburban Hospital, had an appointment with hospitalist director, and I sat down. I was like, "Look, I want to be a hospitalist." Oh, great! We are so happy you're joining us. Like, isn't it nice to have a hospitalist who's also trained in endocrinology? Like, just one condition. I want to do 1 week hospitalist and 1 week want to do endocrinologist work. He's like, I'm not sure how it's going to work. So he said, why don't you put together a business proposal to see how you can combine those two things. So if you ever have to do this, you need to, here's your key stakeholders. So you need to know your hospitalist director, you need to know vice president of medical affairs, CEO, and also have to find people from a Johns Hopkins community physician, Johns Hopkins School of Medicine who can help me with that. So this is my first proposal. I was still a fellow, third-year fellow at NIH. I called it the Inpatient Diabetes Management Program. That's what I knew at that time. So my recommendation is, if anyone asks you to put together a business proposal, please find someone with a business degree. We went to medical school and residencies and fellowship, and we learned very little about the business of healthcare. So I made so many mistakes in my first business proposal, which actually cost me long run. For example, I didn't know, you know how you've heard about this RVU bonus for those who are like, if you see so many patients above your target, then you get an RVU bonus and so on. Did you know that you have to put it in the budget? So I worked so hard the first year, and then, but because it was never in the budget, I never got my bonus. So I had to learn things. So what is the most important question you have to be prepared to answer when you've been asked by a hospital administrator? What do you think?
You're going to generate money.
Are you going to generate money? Very good. Very close. How much does this cost? Very close.
Assets minus liabilities.
Okay, assets minus liabilities.
Bottom line.
Huh?
Bottom line.
The bottom line. So this is the most important question, is how many patients can you see per day? And you know what? When I was a fellow, I was like complaining, like, why do we have to, why is my clinic so packed? Why do I have to see so many patients? But guess what? This is the time to learn to see patients. This is the time to be efficient, to learn how to be efficient. So when you get a call from your residency program director, from a clinic director, if you're a fellow, from an associate program director, like, hey, can you see an extra patient? Just say, yes, thank you. Because ultimately, this is what's gonna land you the next best job. You have, are you doing the clinic? No? Yeah, so say yes and thank you. Because ultimately, this is what's gonna differentiate between you and another clinician when you're applying for a job. Because ultimately, it's all about the RVUs, the relative value units. So how many patients you can see, so you can generate revenue, generate money to offset of your salary and benefits. you have to find a successful model. I was lucky to be exposed to multiple successful models. So at NIH, we had a blood glucose management service. Was decent, not very efficient. I also was exposed at the Georgetown that I rotated here. We had, so when you're a fellow, for those who are residents, when you're a fellow, you go and see patients and then you round at 2 o'clock, right? Around 2 o'clock. If you're working with Dr. Janicic, it's 4 o'clock, or sometimes 5 o'clock. And then at that time, we still had a paper chart. So we would quickly discuss the plan, write our final recommendation. I still remember coming to Georgetown ICU with my recommendations at 4:30 p.m. after doing the rounds. It was Dr. Yi. And the patient is gone. So how is this helpful to the hospital with all my hard work recommendation? Patient is gone. I mean, from a hospital standpoint, they're looking for efficiency. So if I were a hospitalist and I want an endocrine consult, I really have to think twice. If I'll ask for an endocrine consult and it's already in the afternoon, odds are this patient is going to be seen only tomorrow morning, and then we'll round in the afternoon, and then they bring their recommendations. And I have to wait and it will delay the discharge by a whole day. So sometimes hospital is like, hey, if I have to wait for so long, maybe I'm not even going to consult. So at Hopkins, we also have a patient diabetes management service, but being able to know the work in the community hospital setting, just community, like this is a little bit different. You don't, for example, we don't make recommendation, we just change the orders immediately. So I was lucky to work with get a great support from Sharita Golden and Paul Ladenson from Hopkins, Nes Matiodakis, who really kind of helped me to envision a successful model and then adopt it for community hospital setting. So I have a question for you. Where would you get your medical care? Would you go to an academic hospital or a community hospital?
Depends on the medical condition.
Well, give me an example.
Anything more complicated, I would say, of course, we are biased. We'll say Georgetown.
You would go to Georgetown for something complex?
Yeah.
Right, like neuroendocrine tumor or something bad?
Yeah.
I agree with that. I mean, if you have something generic and you go to a community hospital, there's usually better staffing half the time. There's since the rate is, they're trying to make money a lot more than the academic centers, they're built a little bit more efficiently than academic centers, at least in my experience.
So would you go to community hospital or you would go to an academic center?
I mean, if I had a COPD exacerbation or DKA, I'd probably go to a community hospital. If I had a neuroendocrine tumor, I'd probably go to Georgetown. But like I said, I mean, I think run-of-the-mill disorders are treated, a little bit quicker than academic centers. There's a little bit less people in between. At a center like Georgetown, you're going to have a ton of testing done, a ton of things that might not be directly involved in your care. You're going to have a bunch of people consulted, and you're going to be there for longer and potentially take longer to get the care you need. Whereas you go to a community center, you get it done pretty quickly because people are trying to get you out as quickly as possible. So there's less.
Yeah. So we have 948 academic hospitals, and we have more than 5,000 community hospitals. So guess where most of the Americans get their care? I mean, we are lucky to have Georgetown here, Washington Hospital Center nearby. There's some GW, right? This is very unique, extremely unique. I speak with, I gave a talk in March for a family physician, DO family physicians in Orlando. And many of them work in extremely rural area where the nearest hospital is a 2-hour drive. Or if you get in the hospital would be 20 beds and they have to manage everything themselves. So even though we as an endocrinologist, we are trained in a big academic center, so thank you, Dr. Rabalis, for wonderful training. But ultimately, the biggest need is not an academic center which already has maybe 10 endocrinologists on staff, or some of them even have more endocrinologists. The biggest need is actually in a community hospital setting. So I was proposing to create an endocrine hospital model where we have an endocrine hospitalist. We also have an advanced practice provider, but we also work very closely, truly as a team, with a pharmacist and a diabetes educator and dietitian and nurses, with an ultimate goal to reduce length of stay, save money, reduce readmission, improve glycemic control. And while we believe that most of the time is being spent on diabetes and endocrine consultation, by the way, Dr. Verbalis, when they found out I know how to treat hyponatremia, the hospitals were just thrilled. You know who was even more thrilled? Nephrologists. They're like, yay, we don't have to do hyponatremia anymore. So thank you. But most of the time, if you ask me, where do I spend most of my time, is really on the discharge planning. Because in order to make sure that the patient doesn't come back right away, or in a month, or in a few weeks, you have to do thorough discharge planning. You have to invest also in hospital policies, and of course, quality improvement. So we started the Diabetes Champion Academy, where I would go and get a group of nurses from each unit, nursing leaders, and I actually teach them about diabetes. Don't expect that nurses know everything about diabetes, right? We actually have even though we all do orientation, someone would come and talk to them about diabetes, but their knowledge about the new continuous glucose monitors is extremely limited. So what I've done small group nursing education. So I would come to the hospital around 6:45 a.m. I would do the change of shift at 6:50 a.m. We would have a change of shift and do little huddles. I would just get a group of nurses. Okay, let's talk. Let's discuss it. Here's a patient insulin pump. Let me show how insulin pump works. Done multiple in-services, taught them about insulin pump, how to treat hypoglycemia. We had a hypoglycemia policy, but nobody dared to follow it. We had basal bolus insulin therapy, or talk to them about even the concept of basal bolus insulin therapy. And while I was at NIH, I was absolutely spoiled. I thought every nurse know how to do an ACDA stimulation test. But in most community hospitals, we've never heard about the ACDA stimulation test. And even if there is an order in your electronic medical record, you put an order, but it's not going to be done correctly. So you have to educate. I organized lunch and learns for the hospitalists. For example, many of the hospitalists never held an insulin pen in their hand. They don't know that insulin pens don't come with pen needles. So we would just prescribe them the insulin pens and no pen needles, and the patient would come to the pharmacy after discharge from the hospital, like, what am I gonna do? Right, sounds familiar? We actually deployed a complete discharge planning where I do the discharge planning. So for patients who come to the hospital, they have diabetes orders, right? Their medications. All diabetes medications and orders are wrong until proven otherwise. So I reconcile and verify. If I have to call the nursing home, or if I can't find anyone, I ask our pharmacist to do so. But I actually take care of everything, because ultimately, the diabetes care nowadays and discharge planning is so hard. So for example, this patient was at home on insulin Lispro, which is Humalog. But in the hospital, we use insulin aspart, which is Novolog. So most of the hospitals like, oh, so he's an aspart here, so I'll prescribe aspart. So here patient comes home with now prescription for aspart insulin when he has a almost identical insulin, which is called Lispro insulin. Those little nuances, patients get really frustrated with those. We also got a large grant for Johns Hopkins and University of Maryland to deploy diabetes health manager training program, where all of the patients who are being discharged from the hospital, if they're willing to learn or interested, they can get a one-on-one appointment with a diabetes educator and nutritionist. And it's working quite nicely. So I started working at Suburban Hospital, worked for a year, and it was time. Apparently budgets have been renewed all the time, right? It's not that you have a guaranteed job for the rest of your life. You have to show your return on investment. And this is an important lesson. Like, well, it's not good enough when I'm an endocrinologist, I have to show something else? Like, yeah. Remember, if you have no margin, you have no mission. And it's very important. You can be a great guy. You can be wonderfully trained endocrinologist, but if you don't perform or you don't see enough patients, then the administration sometimes find a way to redirect you into other organization or into other role within the same organization. So you have to constantly show the return on investment. So we looked very early. So what's the impact of our endocrine hospitalist program or inpatient diabetes management service? So we just started with just one endocrinologist. I created a glucose steering committee, which is a volunteer group of nurses and pharmacists who want to help and discuss and improve the policies. I redesigned the hypoglycemia policy, and we'll talk about it in a few minutes. Finally, I was able to get some part-time endocrinologists. And remember this guy, Andrew Demidovich, who I mentioned, who got the job and I didn't. So I hired him to be a part-time endocrinologist who would come and help me when I'm not here. We were able to secure some funding for a diabetes educator. But I'm saying secure funding, it's really hard. I mean, you have to, diabetes educators in the hospital cannot bill, so we cannot, even though we make such a huge difference, such a huge impact, but because we cannot bill, everyone's like, oh, why do you need that, right? Your hospital and say, why do we need a diabetes educator? So actually the foundation, the part of Suburban Hospital, which does fundraising, funded this position for a diabetes educator. And here's our study in the first 17 months. So we are co-managed about 18% of the patients at that time. We're co-managing much more right now. And of course, we had higher severity of illness score. The patients who we were managing or co-managing were significantly sicker. But if you look at the readmission rate, and the red line is the inpatient diabetes management service compared to everyone else, to the comparison group, patients who were not co-managed by us but also had diabetes, they had not really significantly changed the 30-day readmission, while our patient had significantly changed. And the same thing happened with the length of stay, a significantly decreased. And obviously, especially in Maryland, there is no perfect financial cost calculator. But when we plugged in the calculator, which is available, we believe that we saved close to $900,000 in the first 17 months. And that's what the administrators want to see. We want to see dollar signs. See, when I talk to, when people ask me, why did you even go to business school? Like, why should doctors go to business school? And it's a great question. And I think that one of the biggest challenges for us clinicians, we speak a different language. When we come to our administrators, say, hey, I don't have time to do research, I'm seeing too many patients. You know what the administrators say? Here's one more extra clinic. So we speak different languages. They speak dollars, and we speak patience. So I think if for those who are considering, I think the business school really helped me to finally figure out the language of the administrators. We also tried to fight the therapeutic inertia at Suburban Hospital. Apparently nobody ordered A1C. A1C is a very important test, really helps over the discharge, but we educated the hospital, make sure that it can be added on. And we improved the frequency of A1C testing. So for those who want to implement similar strategies, there are multiple quality improvement opportunities available. The Endocrine news featured and talked about how other inpatient diabetes team can improve patient outcomes at a reduced cost. I want to shift gears and talk about an important topic called hypoglycemia in a hospital. Has anyone seen hypoglycemia in a hospital? Everyone? Why do you think it's so important to talk about?
Mortality and morbidity.
Yeah, so increased mortality, morbidity. What else?
Increased in hospitalization stay.
Yeah, increased hospitalization, cost of stay. So we didn't even know how much hypoglycemia we have. We don't know. I mean, nobody ever looked at it. So there were some reports someone put together years before arrived to the hospital. So we created our own dashboards. And this is my colleague Nesma Theodakis. When we look at the patient days with specific glycemic outcomes and look at the patient days with at least one glucose below 70 or below 40 or below 54. And we compared our 5 hospitals. So this is Bayview, this is Howard County, this is the main campus, Johns Hopkins, this is Suburban Hospital, and this is Sibley Memorial Hospital. So if you look at the very beginning where we started, our Suburban Hospital rates were exorbitant. I feel like everyone had a hypoglycemia, especially if you were in ICU, and I'll talk about it in a minute. So hypoglycemia is, again, it's extremely expensive. Hypoglycemia adds at least 30% to overall cost to the patient stay. And we're talking about for an average 300-bed hospital. How many hospital beds in Georgetown?
500.
500. So average hospital spends maybe $1.5 million per year on dealing with hypoglycemia. I mean, think about internal medicine residents. So you see the patient who came here for some other reason. Let's say we came for a bowel obstruction, and we are ready to be discharged, and we also had diabetes. And like, you're gonna run, you're gonna discharge, and we walk, and you're ready to send discharge, and now patient has a glucose of 34. Are you gonna send this patient home? Like, I'm not comfortable, right? You're keeping patient one extra day. What happens? Great, you fix the hypoglycemia, but you added the one extra length of stay day. So you added another $3,000 or $4,000 to the cost. So we started the program at Suburban Hospital, and then we realized that even though we had a hypoglycemia policy, nobody read it. It was decent, right? If you have a glucose less between 50 and 70, you give 15 grams of carbohydrates. But guess what? Even though we had a policy, nobody really followed it. So what's the point of having a policy if nobody is following? So I went and educated so many nurses, just one-on-one, small groups, 5, 6 nurses. Let me teach you. Let me show how it's being done. We also completely redesigned our insulin infusion protocol. It turned out that Suburban Hospital still had a goal of glucose between 80 to 110 on all insulin infusion protocol. So virtually every single patient who was put on the insulin infusion protocol developed hypoglycemia. And guess what happened? Nurses disliked the insulin infusion protocol, so we would do whatever possible not to put them on insulin infusion, even if people need it. And we also shifted the nutritional insulin administration to after meals. And I think it really helped with our hypoglycemia because At Suburban Hospital, many of my patients are a little bit older. I would say the average age is around like 70, 80 years old. Many of the patients don't eat in the hospital, so we shifted the nutritional insulin to be administered right after the meal. And if you look at the reduction due to hypoglycemia at Suburban, it's modest, but it's still something that you can show to your administrators. We were able to expand our program to Howard County General Hospital. Andrew Demidovich, who got the job, right, who I hired as an endocrine hospitalist moonlighter, who's also my best friend also. I was able to convince him to bring his expertise to another Johns Hopkins Community Hospital in Columbia, Maryland. So they had a local endocrine group, which is, we've done a decent job. But look what happens if you bring the endocrine hospitalist. Your rates of hyperglycemia rapidly coming down. And then we brought it also advanced practice providers there too. So there is someone else who is looking at hypoglycemia. Anyone heard about it? CMS, that's right. The Center for Medicare and Medicaid Services. So in August of 2021, and we knew that it's coming. It's not new, but we knew that CMS would like all of the hospitals in the United States start tracking severe hypoglycemia, glucose less than 40, and we're going to be looking for the percent patient stays. And we're also going to be looking for severe hyperglycemia, glucose more than 300. And what's going to happen? So in 2021, we announced that they'll have this new quality metrics. And by 2023, hospitals have to decide whether we want to report or not, or some other metrics that they have to report. And it's all electronic. So CMS, you literally upload all the glycemic data and it's all electronic. But in 2024, which is not too far from now, right? It's August. Starting 2024, all of the hospitals will have to make this data publicly available. And I'm not going to be surprised. I'm not going to be surprised. But in 2025, 2026, maybe 2027, hospital will be penalized for hypoglycemia and hyperglycemia. So stay tuned. If your hospital administrator says the hypoglycemia only counts as less than 40 millimole, you should talk to them about it. We also deployed the inpatient endocrine hospitals during COVID-19, where we tried to give the iPads to the patient during the COVID-19 pandemic. I'm so happy that it's passed us for the most part. I think that the trend in general in the United States is where physicians going to be paid for their value and not for the RVUs. We've been talking about for the past, I don't know, 10 years. We are still being paid for RVUs, but value-based is coming. And there are certain challenges. It's very hard to get the data. If you think that the data on length of stay readmission is so easily available, it's not. You have to fight for it. You have to figure out where to get it. And think of this program whenever you're starting a new initiative or you open a new department, it has to be like a startup. And every startup requires an upfront investment. So I'm delighted that Suburban Hospital invested in us. I was so excited that my program is going so well. So a year later, I put together another business proposal to expand and hire a nurse practitioner, and was struck down. I put together another business plan to open a diabetes center of excellence in Bethesda, Maryland, with a cost of $1.2 million. When I brought it to my CEO, she said, no. But it takes time. The next business proposal, be persistent. It's okay. It's okay. Don't always get what you want, right? So just be persistent. So a year later or 2 years later, I brought another proposal and was approved. And I was able to pitch the similar proposal to Howard County General Hospital. It's a big community hospital. to expand the service, and we loved it, and was approved. I also was able to pitch it to the CEO of Sibley Memorial Hospital, which is just 15 minutes from here. It took several years, 3 or 4 years, to kind of negotiate between the CEO, chief medical officer, but it worked out. I recently put another proposal to expand my endocrine hospitalist team at Suburban Hospital and was denied. So I want to tell you that I don't always get what I want, and it's okay. So each hospital administrator is like, well, do you even have enough patients to support a full-time equivalent, full-time position of an endocrine hospital? So this is when at Howard County, when we had a local endocrine group, which is very, very nice, outpatient endocrine group. But look what happens when you bring the endocrine hospitalist. The number of consults is rapidly increasing. We are probably now one of the largest endocrine hospitalist group in the country. We have 5 full-time endocrinologists and nurse practitioners. We have multiple endocrine hospitalist moonlighters who come and help us on weekends. We have internal medicine residents who come and do the endocrine hospitalist rotation with us. We have some of the George Washington University fellows with us, and we're delighted you're here. There are certain advantages of being an endocrine hospitalist. One of them is very flexible and negotiable schedule. So if I have an appointment with for one of my daughters with pediatrician at 10 a.m., I sometimes take them to the appointment. I don't have to cancel any patients, don't have to cancel clinic. I just come to the hospital later, or I come early, or I have to catch an afternoon flight to go to give a talk somewhere. I can come to the hospital at 5 o'clock and see all of my patients. There is no overhead. It's very, very modest. I don't need a nurse. I don't need the maid. I don't really have any supplies. I still own a stethoscope. I do all the prioritizations myself. There are not that many. But when I do it myself, I know it's done. My inbox is empty. I'll repeat it. My inbox is empty. And there are plenty of time for research and teaching. So for the first couple of years, what I've done on Monday afternoons, I would just bike back to NIH and join my lab meetings at the genetics lab and continue finish up my research projects at the NIH. So I'll summarize and I'll ask you a question again. So how would you describe a hospital-based endocrinologist if you were a hospital administrator? Do you think it's an expense or an asset? A little bit of both. The key administrator left. I hope that I was able to convince you it's still an asset, even though on the paper it looks like an expense because we have to pay a salary, but we are truly an asset. So I'll just summarize. The endocrine hospitalist may decrease length of stay in 30-day readmission over time, but it takes time. You ultimately improve glycemic control and save money for the hospital. If you want to do the same program, please invest in nursing education. Invest in nursing education because they're the one who are running the show. Think about the MBA, and there are plenty of opportunities for quality improvement in the research, and you can do them in your free time or in the mornings or in the evenings and afternoons or during your work time. And on behalf of my team at Hopkins, just want to say thank you.